Hello.
So can we have the first
Yeah.
slide of yours?
Yeah, sure.
Yeah. So we are sharp 7:30 and we are all set to go. Can we go live, sir?
Sure, please.
So we are live now. With all your due permission, we are beginning with the session for today.
Sure.
Good evening, everyone. This is Batul from IJCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. And he is none other than a very renowned neurologist, Dr. Subhash Khalsa. Sir is MD in General Medicine, DM Neurology, Stroke Fellowship from NIH Maryland, USA, and Senior Consultant Neurologist at King's Hospital, Hyderabad. With the help of sir, we'll be taking a close look on today's topic, which is brain stroke and overview. Before moving on to today's session, let us have a brief look on what the topic says. A brain stroke, also known as cerebrovascular accident or brain attack, is a medical condition that occurs when the blood supply to the brain is disrupted. This disruption can be caused by a blockage in an artery or by the rupture of a blood cell. Time is of the essence because early interventions can significantly reduce the damage caused by a stroke. So we will be learning more about the topic with sir's wonderful inputs and knowledge upon the topic that he will be pondered. So now without any further delay, I would like to welcome sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you.
Thank you very much, IJCP and the team for giving me this opportunity. I'll be speaking mainly on the brain stroke. If there's one disease which can turn one's world upside down in seconds to minutes, and this happens because of the interruption of the blood supply to brain. You can see here, these are the blood vessels of the brain. And these blood vessels can either get blocked, and that's called ischemic stroke, which you can see here in the left-hand side this black thing, or they can get ruptured, which is called brain hemorrhage. So brain hemorrhage looks like this white thing in the CT scan, and the brain infarct looks the black thing. 80% of the brain strokes are infarctions, and 20% are brain hemorrhage ruptures. Now, both of them need urgent care. It's important to recognize them. But what causes the brain stroke? Well, it's caused because of the disease of the blood vessels. As you can see here, this is the aorta coming out of the heart, and from the aorta, these large vessels go to the neck all the way into the brain. So any disease in these vessels can cause brain stroke, which causes them to either get blocked or sometimes cause rupture. The risk factors are long-standing hypertension, diabetes, smoking, cholesterol. But sometimes the clot can form in the heart itself and can travel all the way from the heart into the brain. And that happens when the heart is having an irregular rhythm, which is called atrial fibrillation, which can come either because of rheumatic heart disease or because of old age itself. And then contraceptives, oral contraceptives can also lead to hypercoagulability of the blood. Now, these are all risk factors of the stroke, but the most important risk factors of stroke is the previous history of stroke or a transient ischemic attack. That means this patient already has had an attack, so has a propensity of having one more attack. Now, how do we suspect or how do we diagnose a stroke? Anything which is focal and anything which is sudden and focal, what we can say a bolt from the blue, on a background of cardiovascular disease, which I said, like hypertension, diabetes, heart disease. On top of that, if anything sudden and focal comes, this can be a stroke. So sudden and focal deficit like a hemiplegia, a monoplegia, like a sudden hemisensory loss, like sudden loss of vision, partial or complete, like sudden dysarthria or difficulty in speaking, sudden aphasia, inability to speak or to understand, facial asymmetry, imbalance, vertigo, confusion, memory loss, unconscious. Now, any one of them, if it happens very suddenly, one can suspect stroke. Now, for paramedics in US, this eponym has been made. It's called Be Fast, so that this will help us remember what are the symptoms which we have to, look for when we suspect stroke. It's called Be Fast. B stands for balance. So if a person suddenly loses his balance, E stands for eyes, which means suddenly if he has blurred vision or double vision or loss of vision. Face, which means as if his face is drooping. Now, when you have to check a patient whether his face is drooping or not, ask him to smile. When he will smile, the droop of the face will come out. Is there any weakness in his arms or leg? For checking the weakness in the arms, ask him to raise both his arms, and one of the weak arm will just slide down. And obviously, if there's a leg weakness, you will notice an obvious limp. Speech, the best thing is to ask the patient, what's your name? That will check two things. Is he able to understand? And how is his speech? Is it effective or not? So this is called Be Fast. Here, the T stands for time. That means this is the time to call the emergency or the time to go to the emergency, so that patient should get the immediate care. It's important that these stroke patients should be immediately taken to hospital, because every minute millions of neurons are dying. It can cause lifelong disability. So the main thing which is to be remembered in suspecting stroke is that the moment you suspect it, it's like a house on fire. We cannot waste time. We have to immediately seek medical attention. Now, sometimes there are other non-stroke conditions which can also look like a stroke. They are called stroke mimics, like focal seizures with a post-ictal palsy, like hypoglycemia, like drug poisoning, like hyponatremia, like migraine. All of them can cause sometimes even focal deficits, ataxia, and sometimes even psychiatric or functional disorders can also look like stroke. But it doesn't matter. Still, we should investigate them and rule out that it's not a stroke, try to come to a correct diagnosis, and then treat them. Rarely, brain tumors, brain abscesses, encephalitis also can mimic a stroke. Now, when we suspect a stroke, the general examination includes, first of all, checking A, B, and C, like is he breathing, and how is his respiration, whether there's any block, and how is his blood pressure, how is his pulse. They're essential things, but we should check for peripheral pulses, because sometimes embolic disease of heart can cause pulse asymmetry. Sometimes Takayasu disease, which can cause pulse asymmetry. Temperature should be seen. Rarely, infective endocarditis can present with fever and stroke. Auscultation of heart is very important, because mitral stenosis is one of the cardioembolic sources. We don't see it as often as we used to see it 20 years ago, but still some of the old patients may have a mitral stenosis. Very important. Fundus should be seen, because normally in acute stroke, you don't expect papilledema, but if there is papilledema, then it may be a venous stroke, or it may be an underlying space-occupying lesion. Neck stiffness, for the same reason, has to be checked, not to miss a acute meningitis presenting as a stroke. So these are general examination findings. So based on our examination, what we see on the examination, we can make a clinical diagnosis that this patient may be having a left hemisphere infarction or hemorrhage. Left hemisphere infarction will have aphasia, gaze palsy, a visual field cut, and a right hemiparesis. A right hemispherical stroke will have a neglect, which means the patient will not look towards one side, he will neglect his space. There will be a gaze paralysis. Again, there will be a visual cut, but he will have a left hemiparesis, because we know the hemispheres are controlling the opposite side. But if it's a brainstem stroke, then there'll be nystagmus, diplopia, and a crossed motor sensory deficit. Now, these are hemispherical strokes, but sometimes you can have a lacunar stroke, which is just this small penetrating artery is causing a very small infarct. Those people do not have any aphasia or gaze disturbances or visual field cuts. They have a pure motor, pure sensory, or a pure ataxic hemisphere. So you can, without even looking at the CT scan or a MRI scan, make a good clinical localization of the stroke. Now, stroke is measured by this scale, which is called NIHS stroke scale, and any one of us who has to treat strokes should have this in one's mobile or pocket and score the patient. The normal person should have 0 score, and as the deficit increases, for each deficit, patient gets a point. So if the patient is drowsy, he gets 1 point. If he's comatose, he gets 3 points. Similarly, if a patient has a normal face, he gets 0 point. But if there's a complete palsy, he gets 3 points. So based on that, you give a score to the patient. Less than 3 is thought to be a mild stroke, 4 to 24 moderate, and more than 25 is thought to be a severe stroke. Now, CT scan is enough, the gold standard to make a diagnosis, but MRI is better, it shows more, but we should not waste time, because we don't want to delay the treatment. The main purpose of doing an acute CT or MRI in acute stroke is only one, to rule out a brain hemorrhage, because brain hemorrhage cannot be thrombolized, whereas ischemic stroke has to be thrombolized. And CT scan in the first 6 hours is usually normal in the case of a ischemic stroke. MRI is better because MRI in ischemic stroke is not normal. It will show you an infarct as early as within half hours of the onset, as you can see here in the MRI sequence called diffusion imaging. Now, whenever we have seen an acute ischemic stroke, and if he is within 4.5 hours of the onset, we must think of giving him intravenous thrombolytic agent, because that can dissolve this thrombus and that can re-establish the circulation, so that the area of the brain which is not yet damaged but is ischemic and is at risk of destruction can be salvaged. That area is called penumbra. So our job is to save the penumbra whenever we see a ischemic stroke, but it has to be done only within 4.5 hours if we are thinking of giving any intravenous drug. So all ischemic strokes within 4.5 hours, think of giving intravenous thrombolytic agent as we give in cardiac heart attacks. Now, exclusion criteria is if the patient is having a brain hemorrhage, that's why we need a CT scan, or if the patient has undergone a major surgery or trauma within the last 2 weeks, or if the patient's on anticoagulants, oral anticoagulants, and his INR is more than 1.7. This history needs to be taken. But there is hardly any exclusion criteria. These are not exclusion criteria. And why I'm showing that is because they used to be exclusion criteria till recently. So age, single or double antiplatelet use, 1 dose of low molecular weight heparin, pregnancy, menstruation, acute myocardial infarction, seizure at the onset of stroke, minor stroke, improving stroke, cerebral microbleeds in the MRI, kidney failure, dialysis, or post-cardiac procedure. None of this is the exclusion criteria. All of them can be thrombolized with intravenous thrombolytic agent if they are with us within 4.5 hours of the stroke onset. And definitely after minor surgeries like cataract or any superficial surgery, it can be done, but not after major surgeries within weeks. Now, once we are thinking of giving the IV thrombolysis, there is no need of sending PT, APTT. All we need is to check blood sugar, because as we said, hypoglycemia can mimic acute ischemic stroke. Now, in ischemic stroke, if we are thinking of thrombolizing, we must bring the blood pressure down to 180 by 110 by intravenous labetalol. We should give 10 milligram. We can repeat it 2 to 3 times, and usually it comes down. But if we are not able to bring it down by labetalol, then we can give other nicardipine intravenous, which can bring it down. But usually labetalol is able to bring the BP down. But if we are not thrombolizing the patient, then we should not bring down the BP. We should bring down the BP only after 72 hours, because suddenly bringing the BP down in the first 24 hours can cause perfusion, decrease in the brain, and it can precipitate the deficit. On the other hand, if it's a patient of brain hemorrhage, then we have to rapidly lower the blood pressure in the first 1 hour up to 140 systolic. So these BP recommendations are very important. So when we are thinking of giving intravenous thrombolysis, there are 2 agents which are available. One is tissue plasminogen activator, which is to be given 0.9 milligram per kg body weight as an infusion, or tenecteplase as 0.2 milligram per kg. They are almost similar in their efficacy. Now, after giving IVTP, a regular neurological BP observation for 24 hours, most important if we have to prevent the bleeding in the brain. Watch for bleeding tendencies anywhere in the body, like nose or gut or urinary tract. No heparin, warfarin, antiplatelet agent for the next 24 hours. No catheter, nasogastric tube or intraarterial catheter, because they may cause bleeding. Now, sometimes the patient can wake up with a stroke and we don't know whether he's within 4.5 hours or not. At that time, CT scan will not help us. We must do an MRI at that time. If the MRI is not showing anything in the flare, that means the stroke is less than 4.5 hours, because flare changes usually take 4.5 hours to develop. That's called diffusion flare mismatch. If there's a diffusion flare mismatch, you can thrombolize it. On the other hand, if there's already a flare change, that means this patient has crossed 4.5 hours. In them, we should not do it. Very important concept in the wake-up. Now, you can have little bleeding, skin bleeding, conjunctival bleeding, sometimes occasionally lung bleeding. One can manage them according to their protocols. But most important, dangerous bleeding is the brain bleeding, which may happen in up to 6% of the cases after thrombolysis. But out of 6%, only 1% of them, it can be little fatal. So therefore, it's a practice to repeat the CT scan after 24 hours. And if there's a mild bleeding, as you can see here, this petechial bleeding, we call it H1, H2, nothing to worry about it. But if the bleeding is more than that, it's called PH1. And if it is still more PH2, at these PH1 and PH2, we should get worried. We should send the patients fibrinogen. And if the fibrinogen is less than 150, then we should give them cryoprecipitate. I recently gave a cryoprecipitate 2 days back to one of the patients because it can stop the further extension of the brain bleed, but it has to be done very early before the bleed becomes very big. Now, one of the new things which has happened in the last few years is that in all ischemic strokes, we should do vascular imaging also and to see whether there's a vessel occlusion. If there's a vessel occlusion, then we should also give them the advantage of mechanical thrombectomy. In addition to the IV thrombectomy, which IV thrombolysis, which they may have already received by 4.5 hours. But if they come to us after 4.5 hours, then we cannot give them intravenous thrombolysis, but we can give them mechanical thrombectomy for up to 24 hours. Now, in mechanical thrombectomy, this is a kind of a clot retriever, which is a kind of a, it's a mechanical device by which we pull out the clot, called disposable stent. Name is Solitaire, Trevo. There are many kinds of clot retriever. But there are strict criteria. Everybody cannot be subjected to this. There are strict criteria. You have to look at the infarct volume. What is the core of the volume? Normally, we do by the eyeballing. If there is such a big infarct volume, you can see this white thing. Almost whole thing is gone. And he comes to us after 14 hours. We should not give him thrombolysis because most of the brain is already gone. So it will not succeed. On the other hand, if the infarct is small, as you can see here, this small dot-like thing, a little more than a dot, and this is even at 18 hours, you can still thrombolyze because still there is a lot of salvageable brain. Now, we do normally this by eyeballing these days, but now with the artificial intelligence, we have got softwares. It can exactly tell us which patient we can do mechanical where it will succeed and which patient we may leave alone. And you can see it on your mobile. Now, if you see in this patient of stroke, this red area, this purple area is the area which is damaged. But the green area is the area which is not damaged yet, but it's at risk of damage. So this is a good patient where you can do mechanical thrombectomy even at 24 hours. Now, beyond thrombectomy, every patient after 24 hours should receive aspirin, 300 milligrams, and later on you can decrease it to 150 and finally 75. Blood pressure, we have already said it should be lowered only in brain hemorrhage acutely. Otherwise, in ischemic stroke, we should wait for 3 days unless we are thrombolizing, then we'll reduce it on the first day. Sugar, electrolytes, and urea need monitoring. Sugar should not exceed 140 because that can also damage brain. And swallowing dysphagia should be do a daily assessment because otherwise they will aspirate. Oral hygiene should be maintained by nurses. Patient should undergo chest physiotherapy. Dehydration should be avoided, maintaining euvolemia. If there are seizures, anticonvulsants should be given, but no need of giving prophylactic anticonvulsants. And another important thing is that heparin, subcutaneous and pneumatic compression devices should be used to prevent DVT. We should not give elastic stockings. They are contraindicated. Now, in some of these stroke patients, what happens is that there is edema, and that edema can become very big and it can choke the brain, particularly on second or third day. Now, in these patients, you can do what is called hemicraniectomy. In hemicraniectomy, you don't operate the brain, but you just remove this brain, this flap of the skull you remove, that gives brain the space to breathe. So hemicraniectomy may be done in these large images. Before we discharge the patient, we have to see what is the mechanism of the stroke. So every patient should have a ECG, 2D, echo, carotid, Doppler, CT, and you have to know that where from the clot came. Did it come from the heart? Was it a cardioembolic stroke? Did it come from the carotid artery? Or did the clot form de novo in the brain? Because based on that, we are going to discharge him and give him the advice to prevent the recurrence. So if it is a non-cardioembolic stroke, we give him antiplatelet agent like aspirin or clopidogrel, or now we can give ticagrelor also. But if it's a cardioembolic stroke, then we give them oral anticoagulant like warfarin or neuro-oral anticoagulant. We also emphasize the patient to do lifestyle modification, exercise, diet, stopping smoking, controlling risk factors like diabetes, hypertension, so on and so forth. Now, that was about the ischemic stroke. But if the patient has had a hemorrhage, then by the hemorrhage itself, we can see what is the etiology. If it is this hemorrhage, big basal ganglionic hemorrhage, most of the time it's a hypertensive hemorrhage. But if it is this lobar hemorrhage, which you can see is adjoining the skull and this rounded. This is lobar, and this is usually because of a disease of the blood vessel in the elderly, which is called amyloid angiopathy. Very important to make this distinction. And of course, if there's a cerebellar hematoma, very important to know this because they can press the fourth ventricle, cause hydrocephalus, so they need immediate surgery. Very important. Now, on the other hand, if in the hemorrhage you find this shagginess here, then you should suspect there may be underlying arteriovenous malformation and subject them to angiogram. As you can see here, there is a arteriovenous malformation. These patients have to be managed either by endovascular closure of this malformation, or sometimes they may need surgical treatment. So even when there's a brain hemorrhage, by looking at the shape and the size and the site, you can see what is the etiology of brain hemorrhage, so that that also can be tackled. Now, site is important because I told you in the basal ganglia that is hypertensive bleed. Now you see here, this bleed is coming in the sylvian fissure. Whenever there's a bleed in the sylvian fissure, you have to rule out underlying aneurysm. And indeed, this patient had the underlying aneurysm. You can see here. This you can pick up by the CT angio or sometimes even the MR angio itself. So please remember, the size and the site of the hematoma is important in suspecting what is the etiology of the hemorrhage. Similarly, if in a hemorrhage, you see a level, you can see a very beautiful level here. And this level suggests that this patient has an underlying coagulopathy. That coagulopathy can be a genetic coagulopathy, like a hemophilia or any other clotting deficiency. Sometimes patients don't divulge because they have kept it a secret. So if you see a level, you must ask all the relatives. Only then they may tell you. Otherwise, many times they don't divulge. But this also can be because of other coagulopathies acquired, which may be because of liver disease, because of kidney disease, because of antiplatelet agents, more important because of anticoagulants. So size, site, shape, contour of the hemorrhage is important for us to know the etiology. So in as far as its management is concerned, in brain hemorrhage, the management is largely supportive, right? So look after blood pressure, look after the physiotherapy, look after the raised ICP. They may need mannitol for sometimes. Rarely we do evacuation of these patients. And we have to find the underlying cause. Because the underlying cause, as I showed you, if it's a coagulopathy, then we have to give them hemostatic agents. Heparin-induced coagulopathy, we have to give them protamine sulfate. Oral anticoagulant, we have to give them vitamin K. These days we have got a new agent which is called 4-PCC, can be given, which can stop the bleeding, right? So underlying cause needs attention. And so the take-home message which I would like to deliver here is, number one, that in our day-to-day practice, if we see anybody getting a sudden hemiparesis, it's usually due to stroke. And it's not only hemiparesis, any sudden neurological deficit. We should have a low threshold for suspecting stroke. Any sudden confusion, sudden vertigo, sudden hemisensory loss, sudden deafness, anything which happens suddenly can be a stroke. Hemiparesis is most common, therefore we talk about it. But any sudden focal deficit can be because of stroke. It may not be, that's also true, but then it could be, we have to rule it out. Quick neuroexamination to confirm the clinical diagnosis, and a good neurological examination should not take more than 2 to 3. You have to only see whether the patient is conscious or not, right? Is he answering? Is he talking? Is he able to smile? Is there any facial, asymmetry? Ask him to both his hands up. Ask him whether he can walk. So just by this normal thing, you can make in 3 or 4 minutes, you can come to a good neurological deficit assessment. And CT or MRI brain should be done to exclude hemorrhage. CT is good enough, but if there's any confusion or if MRI is easily available, you can do MRI, but otherwise CT is good enough. And if you find from the CT or MRI that this is an ischemic stroke, then always consider stroke thrombolysis if it is less than 4.5 onset. Most of the strokes will qualify within 4.5 hours, but there are contraindications as a recent surgery or a patient on anticoagulants. But up to 24 hours, you can consider mechanical thrombectomy in some patients whose infarct is not very big, as I told you. After we cross 4.5 hours and we go to 6 hours, 7 hours, 8 hours, 10 hours, then the lesser the size of the infarct, better are the chances of recovery. That's a patient selection which is done in the hospital by the neurologist and the radiologist. Some strokes who have raised ICP where there's a lot of edema may need a neurosurgical hemicraniectomy so that their pressure is reduced, and this has been shown to improve the survival of the patient. Before we discharge the patient, we must do his echo, we must do his Doppler to know where from the clot had come, and according to that, give him appropriate secondary. That was about the ischemic stroke. As far as brain hemorrhage is concerned, as already said, the management is largely supportive. We must know the underlying cause of the brain hemorrhage and address it. And thank you very much. If there are any questions, I'll be happy to take.
Thank you so much, sir. Thank you for answering for such wonderful inputs upon the topic that you have shared today with our viewers who are here with us today and who have patiently watched this particular session. So thank you so much for sharing your wonderful inputs upon the topic. We have received few questions from the participants, and I would like to put it across to you.
Please,
the
go
first
ahead.
question is, what are the possible complications and adverse effects of stroke imaging?
No, stroke imaging does not have any complication because these are non-invasive stroke imaging. CT scan can give little radiation, but that is not an adverse effect. And MRI does not have any adverse effect at all. So if you are talking of imaging, there is no side effect at all, no adverse.
Thank you so much, sir, for answering this question. We'll move to the next question that we have received. And the question is, what is the cerebrovascular arterial anatomy relevant to stroke?
You should know that there is a middle cerebral artery which supplies the both hemispheres. You should know there is a posterior cerebral artery which supplies the brain stem, and that is the relevant anatomy of the brain. And very rarely there are some abnormal anatomies. You should be aware of them just to explain the location of the stroke. For instance, sometimes there can be a disease in the middle cerebral artery, and you can have infarct in the posterior part of the brain. Now, that is because of some variation in the anatomy. In some patients, posterior cerebral artery arises from the middle cerebral artery. That's called fetal origin of the posterior cerebral artery. So these are not big issues in the clinical practice, but it's better to be aware of.
Thank you so much, sir, for answering this question. We'll move to the next question and the last question for today's session. And the question is, what are the rates of false positives and false negatives in ultrasonography for stroke?
No, you see, ultrasonography is done only for carotid Doppler. It's not done for the diagnosis of the stroke. It is done to see the carotid artery disease. In the hands of a good sonographer, the false positive and false negatives are extremely low, less than 5%. And this should be done by good sonographers only. But ultrasonography is not done for diagnosis of acute stroke. It is done to see one of the mechanisms of stroke in the carotid artery. So the false positives and false negatives are extremely low. Not worry about them.
Thank you so much, sir. Thank you for answering all the questions. That was the last question for today's session. And at the outset, I would like to thank all the viewers for being an ardent participant throughout the session and being with us here. And I would also to thank you, sir, for taking out your valuable time for being here at our platform and sharing such wonderful inputs up with us upon the topic.
Thank you.
Thank you, sir. With all your last comments, sir, we can conclude the session here for today.
No, it was just very enjoyable for me also. I see strokes every day in and day out, but just to make it in a brief presentation to give the gist of it, I enjoyed the experience. Thank you very much.